I want to give you an overview where I think the field's going in the next few years. Obviously, what you heard about today is treating the early relapsing remitting phase of MS, and I want to say that we are getting now to a stage where we're going to have therapies for the more advanced stages of the disease, people that are already in the so-called progressive stage of the disease. Now, what's quite interesting is the definition of progressive disease has changed simply because neurologists don't like to make the diagnosis, because as soon as they make the diagnosis, we're not meant to be prescribing therapies. So way back in the 1980s, people used to be diagnosed really when they were quite low down on that EDSS score, down at 2. And that was really based on history. Somebody would come into the neurologist and say, actually, when I go for a walk, about a half an hour into my walk, my leg starts dragging. And then you'd put in the notes, 30 minutes. And then next year they'd come back and they'd say, my leg now drags after 10 minutes. And provided their examination was abnormal, you would say they had secondary progressive MS. But then since we had treatments, and the treatments are only really available for what we call relapsing disease, we've actually shifted the definition much, much further. So you can see the definition of secondary progressive disease just changes depending on the neurologist you see. So I don't think secondary progressive disease begins at any specific point. I think it's there from the beginning. And this slide, those orange bars just show you the so-called end organ damage, the brain volume loss that occurs in MS. And it occurs right from the very, very beginning, the isolated syndrome, when you get your first attack, relapsing, both secondary and primary progressive disease. Now, the one thing you've got to realize, and this is an important message, is that unfortunately life itself is an age-dependent neurodegenerative disease. Okay? So from the age of about 35, your brain starts shrinking, and it speeds up as you get older. And so if everybody lived long enough, they'd all develop cognitive problems. So life is a dementing illness. Now, people with multiple sclerosis, progress much, much more quickly. So their brains shrink at a rate of about 2 to 7 times quicker than age-matched controls. And so they're going to get to those age-related milestones a lot earlier. And so that's one of the reasons why we have to treat MS as effectively as possible early on, really to protect brains so that when people get older, they've got the reserve to deal with aging. And so that's one of our treatment targets now, is not to think about just stopping relapses, but we want to try and normalize the brain volume loss that occurs in people with MS so that they can age properly. It's an ambitious target, but some of our more effective therapies actually do that. When we switch off the inflammation and render these people activity-free, a lot of their brains are shrinking in the normal range, and I think it's remarkable that we have treatments now that can do this. Unfortunately, once the brain is damaged and we've lost brain, we don't have any therapies at the moment to recover function, so that's why we've got to use our treatments to prevent. So this is the slide that was very, very useful way back, but it's the most damaging slide, in my opinion, in the field of MS. This was actually the 2 treatment cohorts that were treated with this drug called alemtuzumab, Lemtrada. It used to be called Campath. Have you heard about Campath? Campath stands for Cambridge pathology. This drug was invented in Cambridge. It was used to treat leukemias, lymphomas. It's a drug that actually depletes your immune system and allows it to come back, reboots it. And so on the left, you'll see the group of people with more advanced progressive disease treated. And although it stopped them having relapses, they still continued to progress. In other words, their disability got worse. And on the right, we've got the early relapsing patients. And not only did it stop them having relapses, but their disability improved. And Alistair Coles, who's in Cambridge, and Professor Comston put forward this a paper that there's a window opportunity to treat MS. And if you treat it too late, you miss the boat. And so there was this concept, and it's been in the field for a while, that we have this so-called therapeutic window. And I think this is wrong, simply because they never compared that therapy to a control therapy. This is one of the things in life. When you make an experiment, you really have to have a placebo control trial. And so we don't know if those people with more advanced disease are actually benefiting from this, because we can't compare it to people who haven't been treated. And fortunately, the company that manufactures this compound, Genzyme Sanofi, are finally going to start recruiting a trial this year of people with progressive disease to test whether those people are doing better, which they should have done the trial long ago. And we've actually probably had treatments that work in progressive disease, but we never looked properly. So this is actually a slide that tries to describe a trial of our first therapy we had in MS, interferon beta. It's given as an injection under the skin or into the muscle. At the bottom there you see interferon beta placebo. These patients were treated with the drug for 2 years. And at the end of the 2 years, there was no difference in outcome between placebo and interferon. And the conclusion was this drug doesn't work. The patients then were followed up and brought back at year 7. So this is 5 years after finishing the trial. And those that received the drug for 2 years actually were a lot better in terms of their brain volume. They hadn't lost so much brain volume. Their upper limb function was a lot better. Okay, and they had much better cognitive tests. And so what happened was it took that long to show a treatment effect. And that's one of the things about progression, is what's causing you to progress with MS, in other words, worsening disability this year, is probably driven by inflammation a year or 2 ago. It takes that long for it to show its effects. So if you switch off inflammation in people with progressive disease, now you have to wait probably 3 or 4 years to see a treatment effect. And that's what's been wrong with all our trials. All our trials have been really about 2 to 3 years. And now that we started doing trials that run into year 3 and 4, we call these event-driven trials. We wait for people to hit the event. We're getting positive results. So we've had 2 back-to-back positive studies in progressive MS. One on a drug called ocrelizumab and the other one on a drug called siponimod. So I think we're getting there. We're going to get treatments for progressive MS. And when we saw these results, we also realized that it's much easier to see a positive effect in upper limb than lower limb function. And it made us think about this multiple sclerosis being a length-dependent process. What you've got to realize is that the nerve cells from the cortex to the spinal cord, those supplying the legs are much longer. They're about 1 meter long, and those going to the arms are probably about 30 centimeters. And obviously, the longer the nerve fiber, the more likely it is to be hit, and the more vulnerable it is to go to degenerate early. And that's why people with MS tend to, when they get progressive disease, lose their leg function first before their arm function. And so if you try and look in the legs when they've already lost leg function, it's very difficult to see a treatment effect because the pathway has got so few fibers left, it's got so little reserve, you can't see a treatment effect. And so that's probably why we see a much bigger treatment effect in the upper limbs, because it's got reserve. Make sense? And so if you think about the therapeutic window concept, the window is different depending on how long the nerve fiber is and how much reserve it's got. And so I put bladder there because actually for those of us who work in the field know that when people with MS present with bladder function, it's a bad sign. Okay, they do much worse in the long term than people without bladder dysfunction. So we think bladder is probably the first indicator, then it's lower limbs. And you can see, even though you're losing lower limb function, there is a lot to protect still in other systems, particularly in upper limb function. And if this is just another example of a trial. So you all know about methotrexate. This drug is licensed for treating rheumatoid arthritis. And actually, it's the first drug you try in RA. It's given once a week. And way back in the late 80s, early 90s, the Americans did this trial. They took people with both primary and secondary progressive MS, and they put them on low-dose weekly methotrexate based on the rheumatology. The good thing about this trial is they included quite good hand function tests. Most of the people who went into this trial were already quite advanced. They were using walking sticks. So about 2/3 of the patients in this trial had really lost enormous amount of function in their lower limbs. So they didn't have much reserve there. But they had good reserve in the upper limbs. And surprise, surprise, these are the outcome measures in the trial. The EDSS is mainly driven at this stage by walking. And there's a thing called ambulation index, which is a little scale for walking. The drug didn't work in the lower limbs. But if you look at the upper limbs, there's a thing called the 9-hole peg test, which is an upper limb function test that the occupational therapists use. You've got to take this little device and put pegs in, and you take a time. And the other one is called the box and blocks. So that anybody who's had children, you've seen those little toys where you've got to put the shapes in. Basically, that's exactly what it is. And you time how long it takes for somebody to manipulate the shapes in. And you can see those people who got the methotrexate, their performance in the upper limbs was strikingly positive. Strikingly positive. So here's a drug that's been around for decades, tested in the 1980s, early 90s, positive in upper limb function, but we never learned the lesson there. And so we just said this was a negative trial because it didn't slow down worsening of walking. A bit tragic that we've had therapies that have been around for such a long time, and we've always said, oh, progressive MS is not modifiable. This is a lesson that we haven't learned. So this is another very effective therapy in MS. It's natalizumab, and we heard from Rachel this morning that there are 3 people on the islands on this drug, natalizumab. This is a drug that blocks the cells trafficking into the brain. They did a trial in progressive MS. It didn't make it 3 or 4 years, the trial. They made it 2 years. The trial was negative because the EDSS and the time 25-foot walk didn't change. But in the 2 years, you can see on the second day, there's the 9-hole peg test. The trial was positive on upper limb function. So this actually was a positive but a negative trial because the trial was designed incorrectly. What's interesting is these patients were followed up at year 3 in a so-called open label extension. And at year 3, the trial was positive on the lower limb as well. So it took a bit longer to see the effect. What was causing what is causing the walking to deteriorate was the inflammation before they went into the trial. So that's what we call lag. And this is this drug that's just been licensed, and NICE has just given it a red light, saying it's too expensive to be used in NHS. But this is in primary progressive disease, and this is a positive trial because this was an event-driven study, and the average time in this trial was just shy of 4 years. It took that long to get a positive. The top line is the top two there is EDSS, and the second one is time 25-foot walk. This is so-called 3 months worsening, another one 6 months. And the bottom is the 9-hole peg test. And the drug was twice as effective on the upper limbs, reduced the progression rate by about 47% versus 24-25% on the lower limbs. So this supports this concept that the hands are more modifiable. So I think we have thrown the baby out with the bathwater, and we're now having treatment effects at work. Now the average person in our field says these results aren't good enough because what's 20% or 25% worsening in disability? Well, it means a lot to people with MS because the average time this drug will delay you getting into a wheelchair is about 4 years. And we think the average time it'll keep your upper limb function working is probably about 7.8 to 8 years. So people who have this therapy are going to need a wheelchair 4 years later than those who don't. And they're going to have their arm function maintained, being independent for 8 years versus those. Do you think that's significant, that figure? That's the modeling data. Anyway, I'll be very surprised if NICE give us a green light to use this drug in primary progressive disease. So we're going to have these therapies available, but we're going to have to say to our patients, I'm terribly sorry, but the NHS thinks they're too expensive. And I think what NICE say is likely what the Scottish NHS will say as well. They're unlikely to green light it in Scotland if NHS England say no. So what you've got to realize is this trial was done in quite early. So of the prevalent population, the people with the disease at the moment, it's only going to be about 20% that will be eligible under the treatment guidelines. So of that 1,600, I think it'll be about 300, 350 will be eligible. But what's important is all the new cases, all what's so-called incident cases, almost all of them will be eligible for the drug. So, and it costs a lot. It costs about £20,000 a year, the drug. I think it's £19,000 a year at the moment. That's what the list price is. So that's actually the first future. We're going to have treatments for progressive disease. Okay, that's deja vu. I'm going to just point out that when our interferons came along back in mid-1990s, everybody poo-pooed the results as well, saying this is not that effective. And actually, the person who caused the most damage was the professor of neurology at Edinburgh University. He was Charles Warlow. He actually thought these drugs were a total waste of money. They're the same for stroke. Yep. And so when you have that kind of resistance from within the medical fraternity, it actually affects the whole community's attitude to treatment. And so we're built into our NHS, there's a type of therapeutic nihilism that these therapies don't work. But since we've had the interferons, we've moved up about 3 notches in efficacy, and we're now into the zone where some of our new treatments are unbelievably effective at switching off inflammation and stopping ongoing damage. Anyway, we're beginning to think about recovery of function, and we're beginning to start trials now to actually take people and improve their function. And there are different strategies for that. And this is one drug that's been tested right now, and this is actually very interesting. This is high-dose biotin. Biotin is a vitamin, but this is given at about 100 times the recommended daily allowances, 300 milligrams a day, and most people only take less than 10 milligrams a day in their diets. So this is actually, and the reason why this is because there's a group of disorders where you actually have abnormal myelin, and they have an abnormality in enzymes that require biotin. And there's a whole group of inborn errors in pediatrics of what we call biotin responsive leukodystrophies. And so we treat some of them with very high dose biotin. And some, by accident in France, some people with MS were referred to these clinics, were put on high dose biotin, and they noticed some of them responded to it. And we think the biotin actually has 2 roles. It increases the mitochondrial function in damaged axons, and it also promotes remyelination. And this is just the one phase 3 trial, just showing you you can see the purple line at the bottom and the yellow line. The yellow line is the placebo, the purple line is the people, and you can see how their function improved, and it occurs early. It occurs within the first 3 to 6 months, the improvement. And then when you switch over those other people, the placebo, onto active in the second half there, they also improve. So this drug now is in trial. I'm not sure if there's sites in Scotland doing it. So Glasgow's doing this trial, and we're also doing it in London. And actually the trial's recruiting much quicker than expected. I'm on the steering committee, and I'm beginning to see the recruitment figures are way above what we thought. So but this is to improve function. I must point out that not every patient responds. So the responder rate in this is probably in the region of 15%. But anyway, it's a pretty safe therapy, and it's worth having a go if you want for the 15% of people that respond. The other thing is protection. So when you get an inflammatory lesion, and we know that it damages the axons, it cuts them and damages them. Just optic neuritis, one episode of optic neuritis causes you to lose about 1/5, 20% on average of the nerve fibers to the retina. So you can imagine in every lesion, you lose 20% of the fibers. You get another lesion, you're going to lose a few more. And so can you protect those nerve fibers? And we did a trial using a drug that's used in epilepsy called phenytoin. It's an old drug. And the reason why we use phenytoin is because you could get the drug levels up very quickly within a day. You could load them up. And we actually used optic neuritis because we could measure those nerve fibers very accurately using a machine called OCT. It's called optical coherence tomography, and you may even have one on the island. Do you have an OCT machine on the island? Probably do, because the ophthalmologists now don't practice without this machine. They use it for monitoring glaucoma and other things. And you can actually look there, you can actually measure the thickness of the retina very, very carefully. And it's a very accurate machine. So the idea was take people with optic neuritis, randomize them to placebo or this phenytoin, measure the retina at 6 months, and use the healthy eye to compare how much loss it was. And our trial was positive. And we've actually reduced the nerve fiber loss by 30% by using this drug within the first 2 weeks of presenting with optic neuritis. Now this is exciting because we now know that this is a sodium channel blocker. We try and get the pharmaceutical industry interested in doing a big trial of a drug, and they say no. We've been trying to flog this idea to industry now for quite a while, and we haven't been able to get a pharmaceutical company to take it forward. So we find it very frustrating. We've got a trial, though, that's finished, and we'll hopefully be analyzing the results in the next few months of another sodium channel blocker, a drug called oxcarbazepine. The name is Trileptal, and we're adding that onto existing therapies to try and delay progression. Elephant in the room, comorbidities. We don't know why, but people with multiple sclerosis and a lot of other autoimmune diseases tend to have more comorbid disease. They tend to have a higher rate of smoking, higher rate of obesity, a higher rate of hypertension, and a higher rate of diabetes, type 2 diabetes, metabolic syndrome. And we know those things are associated with reduced brain reserve, and therefore their prognosis is worse. So this is just showing you that the brain shrinks with age. And this is from Canada. This is from Manitoba. This is Ruth Ann Mary's showing you that when you just classify people with MS as having what we call vascular comorbidity, and these are people with hypertension and diabetes and high cholesterol, you can see that those in the red line there are the ones that have it do much, much worse. In other words, their MS progresses at a much more rapid rate than those who don't. So if you want to manage this condition holistically, we have to actually target comorbidities. How do we get our patients healthier? Okay. How do we get them healthier? And as healthcare professionals, you've got to walk the talk. You can't tell somebody to stop smoking if you smoke. Simple as that. Nobody will believe you. And nobody will lose weight and exercise unless you're thin and exercising. It's as simple as that. If you want to promote lifestyle comorbidity management, you have to do it for yourself. Otherwise, you have no credibility. Anyway, what we did, in addition to the comorbidities, there has been trials of statins, and this is a trial that was done by my colleague Jeremy Chataway, who works in London. And you can see by using high-dose simvastatin, now this is a big dose, this is 80 milligrams a day. Most people get away with 20 or 40 milligrams for their high cholesterol. This is 80 milligrams. And they did it in secondary progressive disease, and actually it slowed down both brain volume loss and it actually slowed down disability progression. And this was the phase 2 trial of high-dose simvastatin in secondary progressive disease. We've just been given a grant by the NIHR, and there's going to be a pan-UK study, a phase 3 study of high-dose simvastatin in secondary progressive disease, and I'm almost certain Edinburgh is definitely a site. Is Glasgow going to be a site? So there'll be 2 sites, maybe even more than 2 sites in Scotland doing this study. So please let your patients know that there's going to be additional studies. Then remyelination. So there's a big biology around what causes the oligodendrocytes to remyelinate. And I'm not going to go through the biology, but down there you'll see there's a list of 5 agents, and we are about to start a phase 2 trial of a new drug called anti-RGMA to try and promote remyelination. But there's also this drug called anti-LINGO-1. The name of the monoclonal antibody is called oportunimab, and this is going to be given by infusion every 4 weeks. And the drug was originally tested in the optic nerve, and it was shown to actually promote remyelination in the optic nerve in people with optic neuritis. We did a phase 2 study, and we managed to find a responder cohort. So within the study, there was a group of patients that did much, much better than the others. The study overall was negative. And the responder essentially are younger people with shorter disease duration, and using an MRI to select out people that have demyelination. We're now doing another trial, and about only 30% of people who will be screened for this trial will be eligible because they have to have these factors. And so this trial is now recruiting as well, and we are a site. Is somebody in Scotland, are you doing an oportunimab study?
No.
It's recruiting right now. So it's very exciting. You know, we've got studies to delay progressive disease. We've got studies to improve function. We've got studies for remyelination, and we've got data for neuroprotection. So there's a lot happening in the field. One of the things we're missing out on, though, does anybody in the room do rehab here? No. So if you go to our colleagues who do spinal cord injury, they would never do a trial of improved function without adding in an exercise program, because it's like you can't get a pathway to recover unless you exercise it or work it. And unfortunately, we in the MS field are already behind the spinal cord injury field because we haven't built in rehab. So it's something we're trying to push for, is how do we put rehabilitation into our trials. And this is what we so-call plasticity or rehabilitation. I'm not going to go through it, but there's mechanisms at the axonal level, at the synapse level, and also at the cortical level to promote recovery. And we need to actually think about how we design our trials in the future. So I actually think progressive MS is definitely modifiable. And I think we have to actually have a multi-pronged approach to this to improving outcomes. And so there's a thing called the therapeutic pyramid. So in multiple sclerosis, we have to switch off the inflammation. There is no doubt about that. Inflammation drives most of the problems we have. So we have to have an anti-inflammatory therapy. And then on top of that, we're going to have a drug to protect damaged nerves from dying off. We then got to remyelinate them. And then in the future, we'll have stuff to restore function, allow these nerve fibers to recover. And so we're trying to build this pyramid at the moment. And in addition to that, we have to treat the disease called life. Okay? It's a very interesting debate. If you're into the philosophy of medicine, there's a big debate going on should we as a society make aging a disease? And I know usually the knee-jerk response, it's not, it's natural. But it's very important that if we do make aging a disease, we then incentivize the pharmaceutical industry to develop anti-aging drugs. If we don't make aging a disease, it will never get the R&D investment that we require to target aging. Okay? But at the moment, aging is not a disease. Right? So we have to rely on the nutrition experts and non-pharmaceutical companies to develop anti-aging drugs. But there are lots of things we can do to try and promote healthy aging, and it's not rocket science. Smoking, exercise, diet, sleep. There's good data now that sleep deprivation, shift workers, people who don't sleep properly, age much more quickly at a brain level. Comorbidities I've already mentioned. Infections. People with multiple sclerosis that get recurrent infections do worse than people who don't. So we have to really manage the bladder infections really actively. And actually, we were just discussing one of your cases last night that was having a bladder infection every single week or month. And Rachel's put them on a new protocol, and they haven't had an infection for over a year. And so that patient's going to do a lot better now because infections stimulate a microglia in the brain. It probably drives progression. This is not only relevant to MS. I've met some people who work in Parkinson's here today and in dementias. The same issue applies to all neurodegenerative diseases. Infections promote that. And then concomitant medications. One of the big things we're trying to do is get away from using anticholinergics. You may or may not be aware that your anticholinergic burden, how much you take in your life, puts you at risk of Alzheimer's. And it's quite a scary thing, this. Just 3 continuous years of exposure to over-the-counter antihistamines, 3 years, increases your risk of Alzheimer's by 3.4. And that's now been repeated in 3 epidemiology studies. And so I wouldn't be surprised if about 20% of you in this room take antihistamines every day for 2 or 3 months of the year. Who does that? Okay? Yep. So we've got to try and change that. You know, my daughters have got such bad hay fever, they take antihistamines throughout summertime. You know. And the question is, I've got to get them to use inhaled steroids rather, because it's much safer than... But we do the same in our MS patients. We put them on old-fashioned bladder drugs, anticholinergics that cross the blood-brain barrier. We know that it reduces their IQs from studies by 7 points. So oxybutynin, who still uses oxybutynin? You should try and use the new generation ones, because oxybutynin crosses the blood-brain barrier and affects cognition, and would probably almost certainly speeds up progression in MS. It hasn't been studied properly, but based on the epidemiology, we should stop it. And we also use a lot of amitriptyline. We dish out amitriptyline in clinic like Smarties to our patients to help them sleep, for their pain, and all those types of things. And I think amitriptyline is a potent anticholinergic, so we have to think carefully about concomitant medications. So this is a summary of the future. Then prevention. I can't leave this island without talking about prevention. And so these are the modifiable risk factors. I've got to change this because there's another important one there. We can't change your genes. Epstein-Barr virus, we know, is a very important factor in MS, and we hopefully will be able to do a vaccine study in 4 or 5 years' time. So I'm part of a working group that's working up a protocol for a vaccine study to prevent EBV infection. It's not only for MS, because EBV causes lymphomas. Vitamin D, that's a study that needs to be done, and smoking, that's a public health thing. Okay, you've got to get your teenagers to not to start smoking. It increases your risk of MS by 50%. Okay, if you put those together, you put the right genes, smoking and EBV together, you can actually, there's a small group of people that increases the risk by 36-fold. This is the data from Sweden. So they interact with each other. Anyway, there's two ways of doing this. You can either do the whole population, or you can identify high-risk subjects. And so we actually are going to be setting up a national register for children and siblings of people with MS. So we're going to try and get a high-risk cohort of people at risk. And we'll almost certainly come to the Western Isles to participate in the national register. We just appointed Ruth Dobson. She was my PhD student. She's just going to be starting on the 1st of May. And part of her job in the first 3 years is to set up a national register. And we'll be following up all the people in the register. And these are not people with disease. So this is why we're going to need your support. We want to follow up siblings and children of people with MS, because we know that increased risk of getting the disease, to see if we can find a window where we can be able to and use it as a platform for doing MS prevention trials. That's it. Thank you very much.